9, 8, 7, 6, 5, 4, 3, 2, 1.
Howdy, CROC Nation. This is your friend, Dr. Tommy Anelli, your favorite cancer survivorship bus driver. You're walking down the street and there's a little bug on your neck and you start to rub it and all of a sudden you feel this little nodule. One thing leads to another. You go to your doctor, you get a biopsy, you get called into the office, you know it's not going to be good. And the doctor sits down and says, I have some good news for you and I have some bad news for you. The bad news is you have cancer. The good news is that you have thyroid cancer. CROC Nation, welcome to the second part of our module, our learning course called Thyroid Cancer, Well-Differentiated Thyroid Cancer. On my left, Angel Santana. Have faith, let it begin. Angel, welcome back.
All right. I see you're sporting, which we failed to mention last week, a Braves jersey. We'll have to have a separate podcast about that, my friend.
Yeah, well, I will tell you that anybody in the know, anybody who's a fan of baseball, who happens to be a Mets fan, knows that the Braves are one of our three arch rivals, right? The Yankees, the Philadelphia Phillies, and of course the Atlanta Braves. But I will say this for the Atlanta Braves, the jersey that I'm wearing is a Hank Aaron jersey, so I don't think anyone could argue with that. Number two is I give them credit. They won the World Series. They took advantage of us. They leapfrogged us into first place and they ended up with the World Series. Tomorrow I'll wear my Astros jersey to give them some props as well. But you didn't come here to get a sports podcast. You came here to get a podcast to help put in your toolbox regarding cancer. So my introduction about thyroid cancer really is ironic. And we started talking about that last week. And the irony is that thyroid cancer could be one of two things. It could be an anaplastic or poorly differentiated thyroid cancer, in which case this would be a less happy talk. Or it could be what's called a well-differentiated thyroid cancer. And last week we talked about the differences, and we talked a little bit about the surgery and that type of thing, the biopsies and the genetics. And this week we're going to be talking about more specifically, what do we do after you guys wake up from anesthesia? You have this big pad on your neck. The doctor comes in and tells you, got everything, nothing's left. And now you have to go see Dr. Anelli to talk about more treatment for your thyroid cancer. So Angel, what if I told you that you were just diagnosed with thyroid cancer, your surgery went great, you have to go see this knucklehead called Dr. Tommy Anelli, who wears baseball and football and hockey jerseys every day. And you walk into the room and this guy tells you, Angel, I have to give you a radioactive salt pill. What would you think about that?
The whole salt thing is just way over the top for me.
Really bizarre, right?
Yeah, I'm not a salt guy, so no.
No, but I mean, taking a pill for cancer is kind of odd.
It is, because I'm also, when you hear cancer, I think of chemo. I think of,
radiation, surgery.
Yes.
Yes.
So you say pill, I'm like, what is this?
Exactly.
Experimental?
Exactly. Well, again, thyroid cancer, as much as I enjoy it, as much as it's one of my areas of expertise, it really is a very different type of cancer. Many cancers are very similar. So, you would think, what's the difference between there's a lot of difference between a lung cancer and a breast cancer and a prostate cancer, but really those types of cancers kind of behave very similarly. But thyroid cancer is way, not even in the quote unquote ballpark. Forget it. It's way out there. So let's talk a little bit about thyroid cancer. So you've had your surgery. Please, I beg you to go back to our first episode. So you'll be able to catch up with us. But what I would be looking at, the things that I would be keying on when you come to see me is your prognosticators. And I'm a big fan, since I have such bad OCD, of putting things into buckets. So I put everything into a very organized bucket. And with most cancers, I do that, but particularly with thyroid cancer. And if you come in to see me, the most important piece of information I need, besides finding out who you are and what your essence is exactly what bucket you fall in. Do you fall into a low risk bucket? Do you fall into an intermediate risk bucket, or do you fall into the high risk bucket? If you fall into the low risk, your treatment is going to be way different than if you fall into a high risk. If you fall into the intermediate risk, there's a lot of gray area, as you can imagine, right? Too hot, too cold, just right. So intermediate risk has a lot more gray zone and a lot more play as far as involving the patient with the decision making. But what makes a patient low risk, high risk, or intermediate risk? So the first thing I look at is the type of tumor. Again, I want to make sure it's a well-differentiated thyroid cancer. So the cells of origin for these cancers are, the fancy word is the epithelial thyroid cells, the cells that make thyroid hormone, the cells that line the thyroid follicles. These are the cells that are well differentiated. These are either called a papillary or a follicular. You could have a subtype of a follicular called a Hürthle cell, which is a little less sensitive, or I guess more intransigent to iodine. Or you could have something a bit more aggressive called the tall cell variety, which tends to be more aggressive than the garden variety follicular or papillary. But that still doesn't change the fact that you have a well-differentiated, very good prognosticating thyroid cancer. Now, the papillary subtype tends to spread into the nodes in the neck, the lymph nodes, whereas a follicular can spread anywhere else into the body, more into the lungs and elsewhere. So those are sort of the characteristics and definitions. So one of the things that you should, my CROC Nation, if you're in for the thyroid cancer situation, if you hear tall cell, let your ears sort of spock up a little bit, and just take note and ask your doctor the implications of that. From there, I go into the lymph nodes. If the doctor did a good job, they would have done some kind of imaging or examination before they did surgery to find out whether or not they have to do what's called the lymph node dissection, because cancer, as you all know, can spread globally through the body, but it could also spread regionally into the lymph nodes. And since the thyroid is a gland that's located in the neck, the cervical, or the lymph node chain that goes down from the angle of the jaw down into your sternal notch, that's the area that they would be looking at. If a person is a young woman with a very small thyroid cancer and they do a thyroidectomy and there's no lymph nodes felt on examination preoperatively, or there's no lymph nodes noted on a CAT scan or an ultrasound preoperatively, sometimes the surgeons will choose not to even do the lymph node dissection. But if you're an older dude like me and you have, just say, a bigger tumor, or my CT scan doesn't look that pretty, then believe me, they're going to cut out those lymph nodes in the cervical chain, as well as in what we call the central compartment, which is sort of right down from your chin, going down into your sternal notch. So those are the different types of operations. And I would look to see if any of those lymph nodes are involved with metastatic disease. Then I would look at the actual tumor to see if it's spread into some of the lymph vascular channels. So the channels within the pathology specimen, or they're creeping up the sheath of a nerve. Whether the tumors have broken out, not so much from their tumor capsule, sort of the saran wrap that sort of keeps the tumor together, but also through the capsule of the thyroid itself. That has implications as well. I also want to know the size of the tumor and whether it's multifocal, meaning there's many of them. I also, believe it or not, this is a non-discriminatory cancer support podcast and organization, but in this disease, there is a difference between age. So younger people, the defined number being 45 years old or younger, doing better than people 45 years old or older. And you also, this is a gender specific disease. So women do much better than men. So with that being said, we've kind of recapped where we were. Now we're going to be basically talking about what I want to decide as far as giving this radioactive salt pill, this radioactive iodine pill. So how, and I tell this to all of my patients, why on earth would I give you a radioactive iodine pill for something called thyroid cancer? And the answer is, you look at the weaknesses of your adversary. And our adversary in this case is a thyroid cell that makes thyroid hormone. Now, what is the ingredients for this thyroid cell to make that said thyroid hormone molecule? Well, they need iodine. Now, these are not smart cells. Think about it. There's no more thyroid. If there's a layer or film of thyroid cells still left in the neck. Those cells do not know that they're no longer in the thyroid gland. And they're going to want, once they recover from the shock of the surgery, they're going to want to do what they do. They're going to want to continue to make thyroid hormone. So if we starve these cells of iodine and we tell our patients to not only stop putting salt on their food for a week or so, but stop eating foods that have inherently a high level of salt in it, those cells are going to be screaming, feed me iodine. And that's where I come in. I give them a pill. It's iodine, but it's a radioactive isotope, meaning that that particular iodine element isn't your typical table salt. It actually is one that we make in a cyclotron, and it's extraordinarily powerful. Iodine 131 has a half-life of 8 days. Again, a very powerful radioactive pill, which comes with a bunch of directions of how to interact with your family, young kids, women in childbearing ages. You can't cook for your family. You can't be around your family. You have to isolate yourself for a week. It's not a pretty task. It's very complex, as a matter of fact. But that is the rationale before, as far as why I would give you a radioactive iodine pill. The other thing that's really interesting is after you take that pill, we want it to attach and grab to those thyroid cell receptors, but we don't want them to grab other cells that also require iodine, like our salivary glands and our taste buds and our lacrimal glands or our tear ducts. Because if we don't flush that radioactive iodine that's not attaching to the thyroid cells, you're going to have a sore throat, you're going to have a tinny taste in your mouth, and your tear ducts are going to get all clogged up, and we don't want that to happen. So one of the cool things about having your tonsils out is you get to drink lots of fluids, and you get to eat ice cream. With thyroid cancer, you drink lots of cool fluids, and you have to take sour candies. The sour candies help to stimulate the salivary glands to spit out any radioactive iodine that they may have accumulated, the taste buds, the lacrimal glands, and get them out of the body. And it's really interesting, right? Who would have thought that this would be a therapy, is to eat Sour Patch Kids and drink ginger ale all day, and be isolated away from your spouse, which in my case, my wife would certainly enjoy me taking an iodine vacation, I'm sure. Only kidding, honey. You know that I'm only kidding. But you could imagine the stress related to that and being radioactive and not being able to see your kids or your family members or whatever. So that's really the long and short of it as far as the iodine pill. So again, I love to go back before I go forward. So you have this nodule, biopsy is suspicious. They do the genetics, it's BRAF positive. You pick your surgeon carefully, make sure you pick a surgeon who knows what they're doing, has a ton of experience, and you have your thyroidectomy, and make sure they're protective of your recurrent laryngeal nerves, make sure they're protective of your big vessels and of your parathyroid glands. You're all done. You go see a doctor like myself who looks at you, puts you into your category, low risk, intermediate risk, high risk. If you're low risk, the good news is I'm probably going to do nothing. I'm probably not going to give you any iodine. If you're high risk, you're going to get a high dose of iodine. If you're in the middle, then I go to those prognosticators we talked about, and I look at how many of them you have. So if everything's low risk, but you're a male and you're 62, I might consider giving you iodine, or I might just test you and see how you do. But if you're a male, you're 65, you have a positive lymph node, and that's it, most likely you're going to get dosed, even though you're still intermediate risk. So that's kind of the way I make my determination. And again, when I say I make my determination, this has nothing to do with me. This is about evidence-based medicine. This is standard of care stuff. This is American Thyroid Association guidelines. Again, your friend, Dr. Tom here, I don't make this stuff up. This stuff is basically handed to me from people much brighter and much more academic than I am. And we certainly follow those guidelines to the T. Now it comes down to a really interesting part. So now, Angel, you've had your surgery. You were determined to need radioactive iodine. You go on your diet, you do your whole thing. We give you your 2 shots. In the old days, we used to take you off of your thyroid hormone and make you atrociously hypothyroid. Luckily, everybody, we don't have to do that anymore. We could give you some medication, 2 injections, as a matter of fact, called Thyrogen, or alpha thyrotropin is the fun name if you guys want to really impress your dinner guests this weekend. And that makes your body think you're hypothyroid, but you're actually not. You're actually normal, regular, feel fantastic. You're taking your thyroid replacement every day. And all of a sudden, we fool the body once again. The body can be fooled. You get your radioactive iodine. You go through your radiation safety precautions. You have your scan and you have your blood work for your tumor markers, and you come back to see me. And I say, Angel, I have some really wonderful news for you. Your scan was negative. Your tumor markers are remarkable. You are a cancer survivor. You have no evidence of disease. I'll see you in a year. Adios. Pretty good news, right?
That's awesome. I have a question.
Yes.
Only because I always wanted to ask this question, but it never came up. When they're in that process of the radiation,
You mean getting the iodine?
Iodine, I'm sorry, yes, Beatrice, yes. So they can't be around their spouse, their kids. How long is that?
That's about a week.
Okay.
Yeah.
All right. And the reason for that, just to get a little bit.
Because you're radioactive.
Okay. And you just obviously, I know we hear.
Yeah,
the
no.
words.
So let's talk about that for a second.
We
So,
hear the words, but-
so radioactivity comes out in our body fluids. So say that I believe you are the cook in your house, or you're not?
Yes.
Yeah, the way I cook is I ask my wife if she wants pizza, and I go get in the car and I go pick her up a pizza, or I go heat something up in the microwave. That's the way I cook. But you are the cook in your house. So imagine young Ariel, your beautiful, beautiful daughter, and she said, Dad, make me a peanut butter and jelly sandwich. And you're radioactive, and you make her a peanut butter and jelly sandwich. And you are basically contaminating that sandwich with radioactive iodine. Young Ariel eats her sandwich. She ingests radioactive iodine. It goes to her thyroid gland. And guess what? High doses of radioactive iodine are fine because it will kill all the thyroid cells, and you don't have to worry about a second cancer. But if it doesn't kill the thyroid gland, it exposes the thyroid gland and those thyroid cells to radioactivity that can cause a secondary cancer. One of the things people worry about with nuclear explosions and things like Chernobyl, and we all fear, the possibility of what they call a dirty bomb, right, going off in New York City, isn't so much the blast itself, which of course is horrible, but it's the dirty contaminants that come out from the fission of the uranium or the whatever, and radioactive iodine isotopes are part of that, and it gets into the atmosphere, gets into the cloud, and the people that were downwind of Chernobyl back in '86, like mostly in the Ukraine and things. All of this radioactive iodine sort of floated over, and all these young people that were exposed to the radioactive iodine, we're seeing them in our clinics with thyroid cancer. So that's why you want to be particularly careful. Now, a woman who's in childbearing age and gets exposed to radioactive iodine, that's a bad thing too, because you could affect the fetus, of course. So these are all things that are put into consideration when we talk about radiation safety precautions. And we're very lucky we have, Mark O'Brien and his crew over nuclear medicine. I mean, I don't think anybody does as what would you say, fastidious or really comprehensive a job educating patients on radiation safety precautions. And I would have to think my colleagues across the area, across the nation, across the globe that give radioactive iodine, I'm sure they have their own version of Mark O'Brien, who does that, or the other people in the department that do such a great job. But does that answer your question?
Oh, without a doubt. Thank you for that.
Yeah. So now, Angel, you've gotten your radioactive iodine. Your total body iodine scan is negative. You didn't have to go off your thyroid hormone because we gave you the injections. You're feeling good. You're feeling strong. You're really emotionally in a good place because you're a survivor. You've been cured of your cancer. Your doctor said, I don't need to see you for a year, but you do have a job. And this is a really another interesting thing about thyroid cancer that's unique, to thyroid cancer. There is a feedback loop between the thyroid gland and the pituitary gland. And it's a negative feedback loop. So I would like to take a few minutes and explain it to everyone. And by doing that, I think then you will understand how we determine which dose of thyroid hormone replacement each particular person needs. And the name of the medication is called Synthroid, or it could be Cytomel, or it could be levothyroxine. But regardless, think about it for a second, Angel. You don't have a thyroid gland anymore. Does that mean you don't need thyroid hormone anymore?
I would think not.
You need thyroid hormone.
Really?
So now you don't have a thyroid to make thyroid hormone.
Okay.
So now we, your doctors, have to be your factory to make your thyroid hormone for you. So we make a prescription, we give you the prescription. And the good news is that this is a very natural medication. My wife hates taking medication. She hates taking drugs, but God forbid she became hypothyroid. I really don't even think she would have a problem taking Synthroid, because it's a monoclonal antibody made synthetically, the exact formula of what your own body would make. So it's as organic as possible. It's basically what we make. Cytomel is basically desiccated pig thyroid. Now, I know she won't take that because she's a vegetarian, but she would take the levothyroxine, no problem. So now the feedback loop between the pituitary and the thyroid. Now, remember, we don't have a thyroid, but pretend we have a thyroid. If the thyroid gland, and again, forget about thyroid cancer for a second for the purpose of illustrating this point. If the thyroid gland makes too little thyroid hormone, that thyroid hormone level is monitored in the blood by these chemoreceptors in the pituitary, and the pituitary gland, the master gland, sits right in the middle of your skull, recognizes the low level of thyroid hormone. So the pituitary, almost like if you could imagine like Mars Attacks, right? There's the alien spacecraft, that's the main spacecraft that's giving directions to everything else. That's why they call it the master gland. We'll say to the other part of the pituitary, which is, attached by a stalk, hey, squirt out some TSH level, thyroid stimulating hormone. So that second part of the gland starts squirting out that TSH, that gets into the bloodstream. And then the signal to the thyroid is, hey, your guys are goofing off. You're not making enough thyroid hormone. Bring it up. So if your TSH level is normal, that means that your thyroid gland is making sufficient amounts of thyroid hormone. If your TSH level is very, very low, that means that you're making too much thyroid hormone. And if your TSH is very, very high, you're making too little thyroid hormone.
Reminds me of a pool.
Exactly. It's completely, yeah. Oh, it's complex. But I think, did I do a good job explaining it?
It makes sense.
Okay. But here's where it comes into play with thyroid cancer. We always want to keep you guys a little bit hyperthyroid. So now here's your quiz. If you're hyperthyroid, will your TSH be too high or too low?
Well, if you're hyper, I would think it would be too low.
Correct.
Yeah.
Because there's an inverse relationship.
Yes,
that's what we want. So many primary caretakers who take care of thyroid cancer patients, they don't recognize the fact that you guys have to be always a little bit hyperthyroid, because by keeping your TSH level low, you'll suppress any residual thyroid cells that might be somewhere in the body. Keep them from growing. We'll suppress it by keeping your TSH level really, really low, keeping you a little hyperthyroid. Now, check this out. Here's another thing. This is all being done without a thyroid. So it's really by your doctor's orders, by your doctor's prescriptions. This is why you guys need so much blood work done, is because there's a certain level that we want you to be at. So if you were a low risk person, I would just use this arbitrary number and say you need a TSH level of 1. If you come in with a TSH level of 8, that means to me that, oh my God, you're not taking your thyroid medication, or you're not getting enough thyroid medication, and you're in danger because you are now you're too hypothyroid, and we need to bring that TSH all the way down. So we have to increase your thyroid hormone. If your thyroid hormone is too low, so say number one, the level 1, say you're 0.02, that means you're too hyperthyroid. So we have to kind of put on the brakes and lower your thyroid hormone. So thyroid suppression, to keep you guys safe in between appointments to see me, is to keep that TSH level low. If you have high risk disease, that TSH level will be even lower. It'll be about 0.8, 0.5, something like that. But that's really important. I think it's a concept you need to know. And it's called TSH and surveillance. And that's basically what we're looking at. The other thing we're looking at is God gave us a very great gift with thyroid cancer. He made thyroid cells make a marker, make a protein that we can follow. And we can look at this number and it will tell me whether or not I feel you still have thyroid cells in your body or if your thyroid cancer has spread. These two markers are called thyroglobulin and thyroglobulin antibody levels. Now, the only thing I'll say about the antibody levels is nobody truly knows the significance of what a thyroglobulin antibody means, but I know that it might indicate that your cancer is coming back, and it will also invalidate your thyroglobulin tumor marker. So that's the only thing you really have to know about that. Angel, you come see me 2 years after your surgery and after your ablation. And, the first year you did fantastic. And you come to see me. Now we're into year 2. You're not really taking your medicines, bro. You're not taking your Synthroid. You're slacking off, and you come see me, and you can run, but you can't hide from Dr. E. You just can't. And I'm going to check your blood, and your TSH level is 5. And I'll say, Angel, you're not taking your medicine. And then you're going to lie and this and that and say, Angel, don't lie to me. I know you're not taking your medicine. And you'll say, Doc, you're right. Yeah, I'm not taking my medicine. I check your tumor markers. Your tumor marker went from a value of 8 when I first tested you. 1 year after you were ablated with the iodine pill, it went down to less than 0.1. And now, you knucklehead, it's 5.0. What do I do? So now I know something's going on. I'm not concerned because, again, this is well-differentiated thyroid cancer, but I need to find out why that number is 5. So what do? First thing I'm going to do is do another total body scan to give you a low test dose of iodine, check your body to see if there's any radioactivity, see if there's anything going on in your body. Second thing I'm going to do is I'll get an ultrasound, because most likely, if it's going to go anywhere, it's going to go in your necks, into your lymph nodes. If they come back negative, I'll do what's called a PET scan. If a thyroid cancer that's initially amenable to receive iodine to kill those cells, sometimes those cells could switch off and become what's called iodine insensitive. If that happens, then all of a sudden there's hell to pay, because now I can't give you any more radioactive iodine. You have thyroid cancer, but I can't treat you with iodine. So that's just another issue that we have to deal with when we're dealing with thyroid cancer. So the way it goes, again, we always go back before we go forward. Nodule, biopsy, BRAF positive, total thyroidectomy. You're intermediate risk. You're a guy. You're 62 years old. You had a positive lymph node. You get your radioactive iodine. You stay on your Synthroid to bring that TSH down. 1 year later, you're perfect. I restage you. Everything's great. See you the next year. You kind of fell off the bus. You're not taking your medication. TSH went up. Thyroglobulin went up. Iodine scan is negative, but the PET scan is positive, and you have lymph nodes in your neck. What do I do now?
I would think you'd have to start over, but not really, right? Because think about it. This all was prevented. This could have been prevented if you took your medication.
If you took your medication. So you're going back to the surgeon.
Yeah, you have to start over.
You're going back to the surgeon, and the surgeon is going to find out where those lymph nodes are, and they're going to cut them out.
Which again could have been prevented
had you taken your medicine.
Yeah. Now,
in fairness,
I'm sorry.
Yeah.
What causes a person to stop taking their meds? Because they feel that they've overcome that first year.
That could be a podcast in itself. Okay. Compliance. Okay. Why do people with diabetes eat apple pie? Why do people with emphysema smoke cigarettes?
Okay.
Why do people always do what's bad for them? Because they think they're immortal and they think that they're going to get away with it.
It's a shame.
Yeah, well, we'll do a podcast on compliance, but getting back to the point.
So you're back to the surgeon.
Back to the surgeon, we find out where this is, then that's called structural disease. One of the more complicated, and I would say complex, and one of the more, I guess, vexing problems that I see is people who do everything perfectly. That was the point I was getting to, was that don't think, CROC Nation, that everybody who recurs or has a high thyroglobulin level or tumor marker, you're not doing the right thing. There are many people who just fail. I mean, it just happens. And in that case, we try to find out where that thyroglobulin is coming from. Is it coming from a lymph node? Is it coming from a lung nodule? Where is it coming from? More often than not, though, this is interesting. We will never find where that number is coming from. We can't find anything on an ultrasound. The PET scan is negative. The total body scan is negative. And then, you know what I'll tell you, Angel, come back in 6 months and we'll recheck you. Come back in 6 months, we're going to recheck you. And that dance could happen for years to decades until the rest of your life. And you'll die of something completely unrelated to your thyroid cancer.
Wow.
Interesting.
Yeah.
And I want to just end this podcast in this small teaching module, this 2-session teaching module on people who present with already metastatic disease. So you come in, you've had this thing in your neck forever, you don't get it checked out. By the time you do, we cut it out. You got positive lymph nodes, you have lung nodules, you have stage 4 disease. What do we do with you guys? So again, getting back to the concept of iodine sensitive versus iodine insensitive. If you're iodine sensitive, I'm going to just keep giving you iodine until you become iodine insensitive. If you respond, fantastic. If you don't respond, what do you do? In the old days, we would use chemotherapy, and the chemotherapy was horrible and it was ineffective and it didn't work. But the good news for anybody out there with advanced thyroid cancer, and it happens, if you see enough thyroid cancer out there, docs, you will see the bad cases because they do exist. So that's why we're never complacent with any cancer, even the cancer that your quote unquote doctors tell you you picked the right cancer. It doesn't matter. It's still cancer. It can still do bad things. So your doctor has to always remain very, very savvy and very skeptical and has to be very, very determined to keep an eye on you. And in those cases, there's a new set of drugs called tyrosine kinase inhibitors. They call them TKIs. And these are drugs, they're chemotherapy drugs that are they call them targeted agents or monoclonal antibodies. And these agents actually have been found to be extraordinarily successful in taking care of metastatic thyroid cancer. Now, they are chemotherapy, so there are side effects. You can get nausea, you can get you can get hypertension. There's a bunch of things that your doctors have to know about. And again, I would recommend you seeing a doctor who specializes in metastatic thyroid cancer. And as far as new modalities coming up down the pike, wouldn't it be great to be able to turn a switch on cellularly and have an iodine insensitive tumor become iodine sensitive again? There's studies being done for that. There's studies that are trying to reduce treatment for thyroid cancer. We talked about in the old days when I first saw thyroid cancer patients, not only did I take all of you off your medication and make you really profoundly hypothyroid, which we don't have to do anymore, as I told you, but we would also basically overtreat you. We would give everybody iodine. I have a friend that I treated 25 years ago that we actually gave external beam radiation therapy on. And my poor friend, who's a great athlete and just a great human being, has a dry mouth as a result of it. So, I mean, and if you were to come in today, you wouldn't get that same treatment as you did 25, 30 years ago, because less is more, right? Thyroid cancer. There's a doctor in New York City who's a friend of mine. He's one of the, I guess, internationally renowned thyroid doctors in the world. His name is Dr. Mike Tuttle. He's out in Memorial. Mike will let people walk around with positive metastatic lymph nodes in the neck, and he won't think twice about it. He'll say, you know what, you do, yeah, you have cancer. It's in your neck, yeah, it's in your lymph node, but you know what, you can live another 30 years. It'll never bother you, so just leave it alone. Now, Mike can do that because he's at Memorial. He couldn't do it if he was here at Garnet. But, it is what it is. But just to let you all know, not to fear, but make sure you're with the right people. So who are these right people? So we've already told you, you need to go to a doctor, a surgeon who has an expertise in endocrine surgery or in thyroid surgery. You have to go to a nuclear medicine / radiation oncologist / radiopharmaceutical nuclear medicine person who knows thyroid cancer. Then for your day-to-day care, you have to have an endocrinologist who doesn't just do diabetes or doesn't just do, whatever. They have to be very conversant in thyroid. They have to know what levels your TSH levels are. They have to know how much Synthroid they give you to keep you suppressed. Then if you have a problem, something comes up, then you're going to be referred to a medical oncologist who's going to talk to you about some of these targeted agents. If you happen to have metastatic disease, if you have a bone metastasis, you might come back to me for a bit of radiation. But the goal would be still the same, whether it's early stage, not treated thyroid cancer, we leave you alone. We keep a close eye on you. If you're high risk and you get radioactive iodine, hopefully you'll be cured then. If not, we'll have to watch you closely. If you have intermediate risk, some of you will get iodine, some of you will not. It depends on your other factors. And if you do have advanced disease, fear not. There is nothing to fear. We just have to make sure you get to the right people. CROC Nation, again, I implore you, please, if you ever need any advice or advocacy, Angel or myself would be happy to speak to you. Talk to you, correspond with you by email, whatever we can do to help you. We're always here for you. It might take us a day or two, but I promise you, I give you my word that we will get back to you. I really, really hope you guys enjoyed the new direction that we're going to be working toward, making these learning modules for you, site specific. We did a beta test with thyroid cancer. We'll move on to different sites. Next week, we'll probably get back onto a new subject. We have Thanksgiving coming up, so we might have a great gratitude podcast ahead of us. We have Christmas coming up, and as we round the new year into our second year, this CROC survivorship podcast experiment, I'm hoping we'll be getting better and better and serving you deeper and deeper. Angel Santana, your comments.
Awesome two-part series. I'm looking forward to what the future brings. But I think we need to stress on the fact that, what you just said, we're an open book here. We are available for the patient. And I challenge anyone to find any podcast that's going to allow a direct connection to the doctor. This is not a third party. You can reach out to us through our social media accounts. The links are going to be in the descriptions. This is a direct connection to Dr. Tommy Anelli and myself, but you will get a response from him. That right there sets us aside from anything else.
I couldn't have said it any better. Angel Santana, on behalf of you, myself, the entire CROC board, we end this podcast as we end each podcast. We would love to tell you, we would love to reinforce to you that you are important, that you are worthy, that you are deserving of people to take care of you, to advocate for you, to stand up for you, and to help you and assist you in your survivorship journey. We wish you a long, healthy, happy, cancer-free life. God be with you. God help you. God serve you. Peace.